Welcome to this explainer. Today, we're diving into the literal biology of wound healing. We're going to break down some high-yield clinical board review questions to see exactly how our bodies repair themselves.
Here's our roadmap for today. We're covering the core phases of healing, the cellular workforce making it happen, systemic modifiers, unique healing environments, and finally, complications. Let's get right into it.
Starting off with Section 1, the core healing phases.
All right, take a look at this first question. Normal wound healing is divided into phases defined by characteristic cellular populations. What are they? Are we looking at A, hemostasis and inflammation, proliferation, maturation, and remodeling? Maybe B, hemostasis, proliferation and inflammation, matrix, maturation, and remodeling. Or C, hemostasis and inflammation, platelet aggregation, maturation, and remodeling. Or finally D, hemostasis, maturation, inflammation, remodeling. What do you think?
Well, if you guessed A, you hit the nail on the head. Normal wound healing isn't just a series of isolated events, it's a beautifully overlapping biological cascade. Phase 1 is hemostasis and inflammation. Then comes Phase 2, proliferation. And finally, Phase 3, maturation and remodeling. As a quick exam curl, remember that these are overlapping biochemical phases, not perfectly separated steps.
Now let's look at the tensile strength timeline, which is pretty fascinating. At 1 week, we see early collagen deposition, but by 3 weeks, you know what? The wound has only regained 20% of its normal strength. And even after a full year of remodeling, it plateaus. A scar is literally never going to exceed 70 to 80% of your uninjured tissue strength. Kind of wild, right?
Moving right along to Section 2, the cellular workforce.
Okay, here's a classic trick question for you. Which is false regarding polymorphonuclear neutrophils, or PMNs? A, they release proteases that degrade ground substance. B, they use the fibrin clot as scaffolding. C, they are absolutely mandatory for healing clean wounds. Or D, they release pro-inflammatory cytokines that activate macrophages. Which one of these doesn't quite fit?
The false statement is C. Here's the deal. PMNs, or neutrophils, are great at clearing bacteria and debris using proteases, but they actually aren't mandatory for normal healing in a clean, uninfected wound. The real star of the show? The macrophage. Macrophages are the truly indispensable inflammatory cell that swoops in and directs the entire proliferative phase. You literally can't heal without them.
Next up, let's talk about the actual materials these cells are building with. Which type of collagen is synthesized predominantly during the early proliferative phase only to be systematically replaced later? Is it A, type 1, B, type 2, C, type 3, or D, type 4?
It's C, type 3 collagen. Think of type 3 as the body's quick and dirty temporary patch. It's synthesized really rapidly in early granulation tissue, but it doesn't have a ton of tensile strength. Later on, the body enzymatically breaks it down and upgrades it to the much stronger type 1 collagen, which is the predominant material you'll find in mature scars.
All right, let's hit Section 3, systemic and local modifiers.
Healing doesn't happen in a vacuum, so let's see what happens when things get disrupted. What is the principal mechanism of systemic corticosteroids that leads to wound dehiscence? Meaning, why do the wounds literally burst open? A, act as potent vasodilators. B, inhibit the initial inflammatory response and fibroblast proliferation. C, selectively consume circulating fibrinogen pools. Or D, enhance the activity of epidermal keratinocytes.
The answer is B. Corticosteroids absolutely cripple that baseline inflammatory phase we need so badly. They block those essential macrophage cytokines we talked about earlier, and they stop fibroblast migration and collagen deposition. But here is a massive clinical pearl for you. Giving high-dose vitamin A actually reverses these exact inhibitory effects. It's a real game changer.
Okay, on to Section 4, unique healing environments.
The rules change depending on where we are in the body. So how does the wound healing process within the gastrointestinal tract differ mechanically from that of cutaneous healing? A, it relies entirely on epithelial cell replication. B, it experiences a rapid, transient drop in tensile strength within the first 3 to 5 days. C, it requires non-absorbable wire sutures. Or D, the stomach has the lowest baseline blood supply.
It's B.
When you look at GI anastomotic strength, day 1 starts strong because of the sutures holding things together. But between days 3 and 5, there is intense early collagenase activity breaking things down. This causes a critical drop in tensile strength, making that specific window the absolute highest risk period for a dangerous leak. Thankfully, by day 14, we see solid strength recovery.
Let's shift gears from soft tissue to rigid bone. During bone healing following a fracture, what is the correct sequence of structural stages leading to definitive repair? A. Callus formation, hematoma, remodeling, ossification. B. Hematoma, soft callus formation, hard or bony ossification, remodeling. C. Remodeling, soft callus, hematoma, osteotomy. Or D. Ossification, remodeling, fibronectin deposition, soft callus.
The perfect sequence is B. Bone regeneration flawlessly follows this 4-step sequence. First, you get a localized pool of blood, the hematoma. Step 2, that becomes a flexible, soft callus made of fibrocartilage. Step 3 is mineralized ossification, turning it into a hard callus. And finally, Step 4, long-term lamellar remodeling meticulously shapes that bone back to normal.
Bringing us to our final section, number 5, complications and abnormal scars.
Here's a classic clinical presentation. A 24-year-old female develops an unsightly, large, nodular growth over her earlobe 6 months after a simple piercing. The lesion extends well beyond the boundaries of the original piercing site. This is A. Hypertrophic scar, B. Keloid, C. Desmoid tumor, or D. Fibrosarcoma. The correct answer is B. A keloid. A keloid is an abnormal proliferation of collagen tissue that characteristically extends way beyond the borders of the original wound, and it rarely regresses on its own. That is the absolutely crucial distinction here for your exams. It grows outside the lines, whereas a hypertrophic scar stays strictly within the boundaries of the original injury. Okay, our final question for today. Chronic, non-healing lower extremity ulcers can occasionally undergo a malignant transformation into an aggressive squamous cell carcinoma. What is the historical clinical name for this? A. Marjolin's ulcer, B. Cushing's ulcer, C. Curling's ulcer, or D. Cameron's lesion? That would be A. Marjolin's ulcer. This is a slow, long-term scenario where a chronic, non-healing skin wound or a burn scar actually turns malignant, becoming an aggressive squamous cell carcinoma. The big exam pearl here? Chronic wounds demand incredibly close diagnostic observation and a biopsy if you see any clinical changes whatsoever. They can literally turn dangerous.
To wrap up this explainer, I want to leave you with this thought. A scar is not just closed tissue. It is the body's permanent biological record of survival and cellular orchestration. Knowing the intense, beautifully orchestrated cellular war that takes place just to seal a single wound, does it kind of change the way you view the scars you carry?